everyone. My name is Iman Khwaja-Redig. We are pleased that you could all join us for this week's lecture in Volume 8 of our KnowNeuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the KnowNeuropsychology Board, as well as members of the KnowNeuropsychology Committee. We would like to thank our 2023 sponsors for their generous financial contributions of the series. Additionally, we are grateful to our International Neuropsychology Society colleagues for their sponsorship and wanted to share information about their upcoming conference. The theme for this year's INS conference is Culture and Connectivity, Neuropsychology Without Borders. It will be held in New York City from February 14th through the 17th. Before we start our lecture, one of the main goals of KnowNeuropsychology is to provide free, high-quality didactic content to our audience. Every KnowNeuropsychology and KnowNeuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. New to KnowNeuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through APPCN. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Karen Considine for today's lecture titled Neurobehavioral Manifestations of Huntington Disease, Assessment, Diagnosis, and Treatment Considerations. Dr. Considine is an associate professor of neurology at Vanderbilt University School of Medicine and a board-certified clinical neuropsychologist within the Associated Vanderbilt University Medical Center. Dr. Considine is primarily interested in neurodiagnostic consultation within adult neurological populations, including as the lead neuropsychologist for the VUMC's Huntington Disease Center of Excellence. Professionally, he is the co-chair of the Neuropsychology Working Group of the Huntington Disease Study Group and a member of the Cognitive Phenotype Working Group of the European Huntington Disease Network. In these roles, he has published and educated on the non-motor neurobehavioral manifestations of HD, as well as contributed to the ongoing efforts in the field to operationalize a clinical diagnosis of HD that better accounts for these symptoms. And with that, we'll let Dr. Considine take it away.
Thank you for that introduction. So today we'll be talking about the neurobehavioral manifestations of HD with a specific attention to some of the non-motor features. Some quick disclosures. I do have a private practice with forensic clinical research and external advisory components. I do have those organizational positions mentioned. While I may mention some psychotropics and off-label use, these are not recommendations or FDA approved. So we'll talk about the spectrum of neurobehavioral manifestation of HD, along with demographic, motor, and biomarker associations for that development or manifestation. We can then shift to assessment methods for the neurobehavioral manifestation aspects of HD. And then I'm going to touch on some treatment and management options for those clinical complications, acknowledging that neuropsychology may not be as heavily involved in the pharmacological element, but it is important to understand the gestalt available treatments given the extreme need for this type of intervention with this patient group. So a brief overview that we won't spend too much time on is that HD is a genetic condition. It's defined by a CAG repeat expansion of 40 or more on an HTT gene. So HTT wild type is the healthy version, but an atypical development of that protein begins to accrue and cause clinical symptoms at that repeat range. There is a partial penetrance range of 36 to 39, and then some isolated case examples of potential manifestations below that. But for the purposes of clinical practice and research, generally, this is the range 40 that we're talking about. Current clinical diagnosis is based on a 99% diagnostic confidence for the motor symptoms representing complications of that genetically confirmed status. In days with less access to genetic testing, it might have been done on family history combined with the clinical assessment, but for a couple decades now, it is a genetic status is typically known or is sought out in suspected cases, and then a clinical diagnosis is kind of made, or the patient is monitored for that diagnosis. However, we know that the clinical phenotype of HD is far more variable than just motor symptoms, and you'll frequently in the literature see reference to a triad. So there's motor, which can be made up of the classic chorea-like movements, Greek for dancing type movements, which is a hyperkinetic presentation, a little different than tremor, with more kind of fluidity and restlessness. There's other motor features beyond the chorea. But also there's a cognitive impairment and behavioral and psychiatric syndromes that come along with the patient presentations. And there's not a uniform progression in these three domains. So as you can see on the right, there sometimes can be one or multiple domains that is more significant in patients. Awareness of these aspects of HD is critical if we're going to be trying to properly assess the patients, properly make clinical diagnosis, especially if we're going to be trying to update the diagnostic components or advocate thereof. And by early diagnosis, that allows us to facilitate more prompt and early treatment options for patients, provide social supports earlier in the disease course, and make sure that they're getting into the proper clinical trials, as well as design clinical trials that are more appropriate for this type of patient population. So if we think about these neurobehavioral aspects, the non-motor aspects of HD, these are somewhat fluid boundaries, but we can think about cognitive impairment and then some of the other behavioral aspects. So with regard to cognitive impairment in HD, what we expect to evolve over the course of the disease, and we'll talk about the pattern of development in a moment, but overall, these are the types of impairment that we can see evolve in the setting of HD pathology. Bradyphrenia and bradykinesia, slowing of thinking, slowing of psychomotor speed is quite common. It'll affect completion time across all tasks, which significantly so, which needs to be accounted for when you're interpreting exam findings, especially in domains that are not kind of strictly processing speed, but may be impacted by it. Executive is a common one. You'll also see it in fine motor speed, not just graphomotor speed. You'll also see it significantly in visual scanning, more so in vertical scanning than in horizontal, and that is associated with objective neuro findings like changes in saccades, as well as gray matter volume in related areas. So it can be an early sign in this condition that may be picked up by certain measures, especially those emphasizing vertical rather than horizontal scanning. Memory patterns that we see in HD, we see a classic kind of frontal executive pattern of more encoding and retrieval-based deficits rather than recognition-based deficits. But that does expand eventually to include some amnestic features, or at least a lot of false positives or poor executive approach to the recognition trials that can at face look amnestic, air quote, but really be just an ineffective approach to a yes-no paradigm or a multiple choice paradigm for the recognition tasks that we use. We tend to see visual spatial deficits a little bit earlier and then evolving into verbal, but not enough that you would want to kind of strictly abide by that. Executive functions are also affected, and we do see it in the inefficiency of cognitive control. Rather than high error rates early on, it does seem to be driven perhaps more by processing speed or inefficiency of the approach, but not by frank errors or inability to accomplish the task given enough time. Later on, we do see more breakdown of abstract reasoning, problem-solving approach. These area of cognitive functions, metacognitive areas of functions, may not always be objectively tested, but there are bedside tests and maybe in vivo examples of these kinds of deficits, which include metacognitive deficit in awareness of symptoms. Anosognosia is a classic syndrome in HD, both for the motor symptoms. Patients will acknowledge them once you put them in front of a mirror, but then when you walk them away, distract them for a few minutes and ask them, are they moving? They'll deny it. But similarly, they will deny cognitive and behavioral symptoms, other symptoms, systemic symptoms. And so you should be aware of that, and it can present fairly early in the disease. Time perception also appears to be altered, and that may be due to the neuroanatomical underpinnings of the disease, which we'll talk about more. And we know that there are social emotional functioning deficits that we can test objectively, though there are less measures widely available. They are increasing in availability, which is good. But negative affect recognition may be compromised in this group. And so that's something that can be tested for, or at least in a clinical research sense, may be interesting to us from a non-motor symptomology perspective. From the non-cognitive, air quotes there, we do see behavioral dysregulation, including kind of the frontal behavioral syndrome. So impulsivity or disinhibition, perseverative thought, which doesn't have kind of an anxious component to it, or the obsessive compulsive thought, which may have a little bit more of the fixated thematic perseveration. So it's always the same thing or things, as well as maybe some anxiety that happens if a behavior is not engaged in, or something is not kind of completed or addresses that thought. Apathy and avolition can be quite significant in HD, and can be a significant impairing force in HD. Beyond what we'll talk about next, the kind of aspects of that may arise in a depressive syndrome. Psychiatrically, depression and suicidality, especially early, can be seen in HD. Suicide in family history is frequent when you're taking a family history, even in those who were not formally diagnosed in eras prior, where perhaps diagnosis wasn't as accurate or available. Irritability and aggression can also be specific to HD, more than just kind of mild irritability. This can be kind of quite frankly, interpersonally disruptive irritability at work or with family. Anxiety is a third common component. And I would point out that for anxiety and depression, making sure that you understand that or verifying that this is a symptom that's subjectively endorsed or described by the patient is important, because motor restlessness can look like anxiety to the clinician or to a family member reporting this, and the apathy or avolition can look like depression, even if the patient isn't feeling effectively that experience. So there are alternative mechanisms that can appear like a psychiatric mood syndrome that should be trying to, I guess, delineated. Mania or hyperthymia can also be present. And that comes also sometimes with psychosis, and it can have some complex delusions. Erotomanic is not uncommon, paranoid sometimes, but that is in a psychotic episode in the setting of a gene expansion is probably an HD related thing, not just a comorbid primary psychotic disorder. And then I'd like to talk about the bioimperative pursuit syndromes. So that includes consumption behavior. We can see sugar hyperphagia. You can also see like alcohol or cigarette kind of rapid rise in consumptive behavior. Sometimes food hoarding, or they tend to lose weight, which is a non-motor feature, but kind of a systemic issue. And so they may be eating more, but also losing weight, which is something to be mindful of. Insomnia early on is quite common, and it can persist and worsen through the course of the disease. And sexual behavior can change. there tends to be a rise and fall in sexual behavior in HD as the disease progresses. Men tend to have more sexual impulsivity, but women as well. And sometimes it can be related to some of the manic or psychotic symptoms. But there is probably more frequently an eventual decrease in sexual behavior. So reduced libido, reduced interest. But this can evolve in a patient. If we try to think about the prevalence and course of this dysfunction, when we talk about prevalence for these two or the larger buckets that I mentioned, we'll start with cognition. There's a very high prevalence. So eventually anyone with HD will have cognitive impairment. It's not going to be selective in that regard. The onset and rate is a little bit more variable, but the course is always progressive, like any neurodegenerative disease. The onset, we believe, may be a interaction between the number of repeats combined with age and perhaps neurocognitive reserve, along with comorbid factors that may pre-exist the onset of the cognitive symptoms that might affect kind of the course. But there's enough research that has had null findings for CAG repeats being strictly related to cognitive age of onset or the rate of decline, that we can't pin it just to the genetic kind of variable. And so there's probably, it's more complex than that. We're going to see a little bit more of this, but the course of the cognitive symptoms, the onset and then the progression may track more with the motor symptoms than with the behavioral and psychiatric symptoms. And we can talk a little bit more why that might be in a few slides. As for the prevalence, that is a kind of point prevalence, if you're in a premotor onset stage as a patient, about 40% probably would meet criteria for MCI. With it rarely there being findings that would suggest a dementia. So early, very close to where motor symptoms have gotten to the point where a clinical diagnosis of a motor onset HD would be made. Most people would probably meet the MCI criteria, even if they are denying it. Informant or clinician observation or exam would reveal it. There's not much dementia at the very, very beginning of a motor onset. However, once we get into motor onset, cognitive impairment at the level of dementia becomes the rule, not the exception. Everyone is affected within that kind of 5-year window, with a minority being somewhat resilient against that. But most of the time you'll find at least enough to meet criteria for a dementia syndrome. If we shift to those other non-motor features, the behavioral regulation, psychiatric syndromes, and bioimperatives, there's a wide variability in the incidence among those syndromes. I would say there is absolutely 100% incidence of a behavioral or psychiatric syndrome, but it's going to be unique for each patient, and that is part of the assessment that needs to take place. It's probably influenced both by the neuropathological factors that are variable among patients, as well as maybe some developmental and psychosocial factors that predate perhaps the onset of the symptoms and may color or influence how this patient evolves phenotypically. One thing to keep in mind is that because of the age of onset being fairly young in this group, with many patients having symptoms in their 30s, 40s, and 50s, that means that many children who are at risk for the genetic condition grew up either influenced by these symptoms or observing them kind of happen to a close family member, like a parent. And that's going to have its own unique impact, especially from a psychiatric perspective. And that is one of the factors that's kind of confounded some of the research in this area, is how do you delineate out the lived experience of being in an HD family from being the HD patient and developing kind of these symptoms. The course, unlike cognitive and motor symptoms, can be much more variable. Stabilization early on is typically accomplishable if there's medication compliance, even if it's not complete remission. Optimization of that symptom is typically something that can be accomplished. The exception is progressive apathy, which seems once it begins to progress, we don't have great pharmacological or treatment options beyond trying to kind of accommodate or work around that apathy. The severity of the psychiatric and behavioral symptoms increases in the 5 years prior to motor onset. So there's a window where they're actually at increased risk for these syndromes, as opposed to how we saw in the other or in the cognitive domain, that maybe in the first 5 years after the motor onset is when that significant impairment jumps. There is a thematic shift that we can note, that we go from a more externalizing psychiatric behavioral syndrome to a more internalizing psychiatric behavioral syndromes as the disease progresses. So from more problematic because they're getting into trouble to more problematic because they're not doing self-care or they're not able to engage in the world as adequately. You can look on the right here for some of the prevalence within HD for the various syndromes that we talked about. It understandably varies across studies and based on the patient populations, as well as kind of some little caveats, so to speak. Sleep-wake disturbances is quite common but non-specific. And then we talked about all the way down at the bottom, psychosis in the presence of a genetic expansion is probably HD related, not something else. But you do have to think about alternatives that might not be genetic, or that might not be an HD genetic pure cause for these patients, especially as they go through the journey of diagnosis, coming to realization of what's the symptoms that they're going to see and all the complications thereof. So if we kind of look at some of the data, I won't spend too much time on this, but we do get a different mix of what the patient's initial presentation is going to look like. About a third have a pure motor onset, but then the majority will have at least one psychiatric or cognitive symptom prior to the motor onset, with depression being a very common one, and apathy, cognitive, and irritability component being another common one. These are percentages within that 40%. And then there's a minority group that seems to be having multiple of these. It's all mixed together. So with CAG repeat length, you can see that that is more convincingly associated with an age of onset, with more CAG repeat length being associated with an earlier age of onset. Arguably, but with mixed results in the literature, the lower your length, the slower your progression from each of these kind of symptom progressions as you go along from behavioral and motor features, but that is less reliably found in the literature with some more mixed findings. The graphs on the right are basically kind of just visually expressing some of the stats I put in the bottom right. They're certainly reviewable with the McAllister 2021 paper cited down there, if you'd like to explore in a little bit more depth the various onset patterns there. For the sake of time, we'll move on. We'll talk about how to integrate a prototypical clinical pathological progression. This is not a perfect graphic, but it's one that I kind of sometimes even use with patients because I think it helps bring a lot of pieces together in a fairly simple visual manner, which is that we do have individuals on the far left who are asymptomatic, that is to say no symptoms, but they are genetic carriers. We believe that they're going to progress to develop pathology as well as symptomatology. In the prodrome, we would expect there to be some cortical striatal degeneration in the basal ganglia, the caudate nucleus, some of the prefrontal cortical areas. That is not always evident on imaging, sometimes evident with quantifiable imaging. In research settings, that's more common than clinic. At a more fine-grained level, we do see changes in the D2 spiky neurons, motor spiky neurons, and that's something that clinically we see as much, but it is probably the one of the pathological factors that contributes to the symptoms we see. In that prodrome, we're also seeing rates increase of processing speed slowing, depression, irritability, occasionally psychosis. That is like I said, it's 5 to 10% of the patients, but it is specific to HD. Around the motor onset, when the symptoms are more meet the diagnostic confidence level that would meet the criteria for kind of a motor onset HD, we do see that's when more profound executive deficits on cognitive testing become evidenced, as well as the anosognosia syndrome is something that's not uncommon there. As the condition progresses, we see that kind of introversion that I talked about, instead of the externalizing, the internalizing of behavioral psychiatric factors. So there's a akinesthesia, there's an apathy, and there's reduced function in memory that looks a little bit more amnestic sometimes. They can be absolutely quite forgetful. There's also a lot more physical complications that aren't listed here, like wasting, dysphagia, difficulty swallowing. Sometimes PEG tubes are required. But once you hit into the mid range to late manifest, there's a lot more disability, multifactorial disability. It's this prodrome and up to motor onset that neuropsychology is really strongly invested in trying to contribute, because it's a gray area. And we can talk more about our role in that area. After the motor onset, it becomes a little bit more of tracking some of the complications thereof. But it's two different kind of roles right now. So as I alluded to when we talked about the syndromes, we can see that there seems to be some neuroanatomical correlates of the dysfunction we're talking about. This is a very nice study by Garcia Goro and colleagues in 2019, where they used multifactorial neuroimaging. I mean, you can see on the left, there's VBM, there's cortical thickness, and some other factors that they calculated. And they used them in a kind of a regression analysis, so to speak, to account for the clinical syndrome seen in the patients. So in 43 gene carriers, 20 pre-manifest and the rest were manifest, motorically that is. This component analysis allowed for them to kind of find the correlates in structural biomarkers with the clinical syndromes. And the cognitive and motor symptoms seem to correlate together, and with the structural findings, specifically with reduced gray matter, cortical thickness, and white matter integrity in frontal and subcortical circuits, specifically the dorsolateral prefrontal cortical and sensory motor to dorsal striatum networks in the caudate and putamen. And that's visually represented over here on the left. And that, I think, adds confidence to our kind of clinical opinion that if you see motor symptoms, cognition should be there as well. The absence of motor symptoms tends to mean that there might be a better chance that cognition is more relatively more preserved. But once it's present, it is a shared march by those symptoms. Now, that contrasted with using the same approach with the remaining symptoms, where they found that the behavioral and psychiatric profile was more associated with reduced cortical thickness in the limbic and paralimbic regions. And that is affecting the ACC to ventral striatum. And so this is, I think, a nice demonstration of two orthogonally related, so correlated but not fully, pathological processes that have shared pathology, though can kind of develop in parallel at different rates or in different patients. If we want to shift gears to discussing how neurobehavioral dysfunction affects the functional status of patients, there are some takeaways that we know about. While motor symptoms are kind of at face a principal consideration in a movement disorder as a functionally impairing symptom, in fact, patients and family are far more frustrated with the functional impact of the non-motor symptoms. And so that's going to be bread and butter in conversation in clinic, what patients most and their families most care about they're happy about treating the motor symptoms, but they're far more preoccupied and frustrated by the non-motor. Anosognosia can sometimes, if present, which it seems to be present in a well, it's probably close to a majority. In my clinic, I see it in maybe 60% of patients. I do have a paper out on a fairly large sample that reflects about that percentage. And that can contribute to a discrepancy between the report of the patient and the caregiver. And that may play a role in some research findings, but in clinic, you have to be careful to make sure you check with multiple sources. There's also the evolving impact of the externalizing, the cognitive impairment and the externalizing behavioral psychiatric syndromes on functional safety issues like criminal behavior, sometimes civil infractions, as well as driving safety and unsafe kind of financial or unsafe decisions, and then poor financial decisions. And that can evolve, as we talked about, over the course of the disease. The sources of that functional decline have been studied, and the ones that after you begin accounting for kind of the diversity of symptoms in your presentations, cognitive impairment seems to be a solid contributor. Even in the setting of motor impairment, we have an R value in the moderate range there at 0.5. Apathy is strongly associated as well, especially in earlier HD, and that remains significant and substantial as an effect size after you account for executive cognitive dysfunction and after you account for motor variants. So it is notable that apathy seems to be an independent construct within this group. It's not just a complication of a frontal executive cognitive presentation, nor of a secondary or just a comorbid kind of epiphenomenon of the motor dysfunction. Depression is another one that meets that high impact effect size. It's because depression is non-specific to HD and is probably significantly influenced by psychosocial factors. It gets a lot of attention, and researchers who investigate the meta-analyses of these acknowledge that there may be a sampling issue here, that depression is constantly looked at. But regardless of that caveat, it does have large effect sizes, sometimes larger than 0.5, although there are examples of where depression is less predictive of functional status after you account for other non-motor factors, like apathy, cognitive impairment, motor component, or motor dysfunction. So there's two broad ways that you could kind of think about approaching neurobehavioral dysfunction in HD. We all, as neuropsychologists, have our bias, but we need to talk about both because there's, I think, a utility in using the right type of assessment for the right patient, for the right type of patient. So while we have neuropsychological evaluation on the right, and there is, this is the criterion standard for detecting and characterizing these neurocognitive disorders. And it helps try to delineate behavioral syndromes and comment on whether they're present and associated with the same pathology as cognitive impairment, or are they a comorbid psychiatric factor, or et cetera. It's critical for confirming that HD pathology may be kind of emergent in patients who don't have motor symptoms. I think that's kind of the patients I most like to work with, is when there is this question of, is this depression and we don't have to worry about that motor symptoms are right around the corner, or that cognitive decline is about to begin, this progressive march, or is this kind of having trouble at school or having trouble at work and having something non-specific executive symptoms? Is this actually a neurocognitive disorder emerging? You're familiar with the length of these types of evaluations, and that's kind of one of the downsides. When I give advice to my neurologists and psychiatrists that I work with, I think that a patient who's asymptomatic, it is an acceptable referral if they're interested. And that could be used for baselining. I like to talk to the patient and make sure that they're aware that we could pick up something on exam, even if they are subjectively asymptomatic and their partner says they are. And they should be aware that that could happen. And so there's almost another level of informed consent that I think is important to have for these patients. Most common I see is symptomatic premotor manifest, that they are concerned or their family is concerned about cognitive change or behavioral disturbance. And then I'm seeing them trying to delineate, is this HD related, something else, both? Early HD is another group that I will see sometimes for follow-up if we're trying to characterize or confirm a progressive course, if that was important, or to evaluate for a treatment response. If psychosis was treated, now let's see how much was that kind of complicating the previous cognitive exam. And then sometimes I'll see patients anywhere around here or beyond early HD. If there's a disability complication, a legal complication, as much as I can play a role as a clinician and not drift into the forensic area, or if I need to tell them they need to get a forensic eval, that sometimes has happened. Sometimes for clinical trial eligibility, there's a question of, is this person eligible? And so the neuropsych evaluation might answer an inclusion or exclusion criteria for that CT. The neuropsychometric screening, we won't spend as much time on, but I'm going to give a reference for both these because our working group just published in the last 3 months on both, a position paper on both. So you can dive into those to get more meat to chew on. But this is where I've spent some effort trying to, because HD patients tend to centralize at centers of excellence where there's clinical trial opportunities and specialized services, we try to coordinate with satellite clinics around the country where these HD patients may be seeing a local neurologist or a local psychiatrist, or maybe getting monitored by their primary care doctor. And I think that neuropsychometric screening is a way for neuropsychologists to project ourselves a little bit forward upstream to the referral to try to give some empirically based metrics and cutoffs that can trigger a treatment kind of response or a referral response as needed. I think that all of them, when you have a neuropsychometric screening, whether it's cognition alone or cognition and neuropsychiatric symptomology, you should try to provide or some context for your potential referral source for what cut scores you would recommend. And we talk about that, or I'll reference that more. And make sure that there's an informant report, and we can't just rely on the patient report. Some of the cognitive ones I'll just mention here, and I'll cite the paper that can go into more detail on other domains. But the Unified Huntington's Disease Rating System, which is used both in clinic and research, does have a cognitive section, along with a motor score section and a functional section, the TMS and the TFC. So a physician who's familiar, a neurologist, perhaps a psychiatrist who's familiar with HD could rely on this, and that's sufficient if not perfect. A MoCA plus an HD specific questionnaire plus a functional scale, that gets a little bit more kind of rounded. And I'll show you that citation where we see different approaches for how to make maybe a neuropsychometric screening packet if you're going to be trying to route or triage these types of patients. This again, if I was to use this, I would use this far more likely in asymptomatic patients. A positive finding won't trigger a symptom onset diagnosis, even if we were to use non-motor symptoms for that. It would just kind of be a red flag that, hey, we need to talk about this. Certainly in symptomatic premotor manifest, it could be used to characterize the patient. So when they come in for the neuropsychologist, there's a little bit more understanding of what's going on to help that evaluation. Manifest might be more useful for just tracking. As I say, it's not going to trigger a referral to neuropsychology, but if that provider is trying to monitor the stability or the course progression, you could empower them to do that without the neuropsych by using a screening form. So what about management? We're going to go kind of quickly through this so we can spend more time with questions, because not many of us, if any of us, are prescribing per se, but it's good to be familiar with these elements. So for cognition, most repurposed and novel agents have failed trials. So there's not great kind of standard operating practice for treating cognition. A lot of the patients come on ADHD medications because sometimes their early symptoms were misdiagnosed or they convinced someone to get them on the stimulant. Those tend to worsen irritability, can trigger mania psychosis, can actually exacerbate chorea. And so it can be a journey to get them off those medications. But sometimes it's just deferred, that if they're doing well and those complications haven't been identified, that you just kind of wait for that conversation later on. You're looking also for, if you're trying to do med management, are there medications that might be actually causing cognitive symptoms? If we're not treating them, can we find a way to reduce adverse events? So look for your typical contributors, because a lot of these medications are being used because of the non-motor symptoms. So they're at high risk for these side effects. You can also work with, more commonly, what we try to do is get speech cognitive rehab and try to involve the family as best we can. Because of anosognosia, it's sometimes better to have family members there to facilitate this role and have it applied in the real world. That tends to work a little bit better. From a mood perspective, beginning with SSRIs or SNRIs is not uncommon. If there's a sleep disturbance, you could use mirtazapine or trazodone. Neuroleptics for anxiety is treated as a second line option. And you can, these patients can engage in cognitive behavioral therapy earlier on in the course if there's not an anosognosia syndrome. Or the CBT can target something that they agree is there. So if it's just insomnia, or there is, if they acknowledge irritability but not other factors, then you could kind of try to see if there's a provider who would do that. Irritability and aggression, prescribing providers tend to try SSRI at near maximum dose before going to sedating options as second line. In apathy, like I said, it's not very responsive to treatment, but typically you try an SSRI if it's possible that this is an anhedonia or dysphoric kind of mood disorder rather than just a true neurogenic pure apathy. Stimulants can be aggravating, so again, it's not a great option, just like for the cognition. There is a thought that applied behavioral analyst could be used for this type of role, which is to say building up environmental structures or observing the normal patterns and looking for things that seem to attract their attention or get them engaged. There's not a lot of work like this, but I think it's an interesting area to try to use the ABA stuff that comes out of neurodevelopmental world in some of these neurodegeneration areas. For OCD and perseveration, you'd use what you'd see in a psych setting, which is an SSRI initially. Olanzapine, risperidone can also be done. Impulsivity and disinhibition, frequently what they'll start with is an SSRI and a neuroleptic. Sometimes a mood stabilizer if there's this kind of labile affect aspect. A nice consideration that this group in the bottom left citation noted is that for some patients, because dysarthria, which is a non-motor, well, I guess it's a motor factor that we haven't really talked much about, these patients can sometimes be frustrated by dysarthria interfering with their communication, as well as cognition interfering with their communication. And there's been some findings that providing communication devices or intervening to facilitate communication and facilitate independence in a functional sense reduces those outbursts. And that is something that sometimes is overlooked and can be brought up into recommendations. Psychosis, like many psychiatric primary presentations, you'd start with a second-gen neuroleptic, given the advantageous profile, and sometimes serotonergic antidepressants if there's a perseverative component. For sexual behaviors, if you have two kind of hypersexual behavior, Paxil is one medication that's used because of its impact to libido. Sometimes a neuroleptic that does have the sedating component. For hyposexual behavior, which is sometimes it's frequently an issue, a PDE5 inhibitor sometimes can work both in men and women, and sometimes is an important part of treatment, especially early on when otherwise they're physically healthy and a young adult in a relationship. Sleep-wake problems can respond to sleep hygiene, to optimizing other conditions. Melatonin sometimes works. Like I mentioned above, trazodone and mirtazapine seem to be nice options given their dual indication. So if we're going to have a couple of takeaways, key points, about 40% of HD patients are going to have one or more neurobehavioral symptom prior to their motor onset, right? That's pretty impressive. And so the most common is sleep-wake disturbance, but that's not very specific. A little bit more specific is apathy, irritability, and depression. At motor onset, you have a huge jump in mild cognitive impairment. And so you are kind of working in that space as a neuropsychologist before and then through. There are, it seems to be two neurobiological phenotype patterns, a psychiatric behavioral pattern tracking with ACC ventral striatum that may have an earlier onset and a fluctuating evolving course, especially in response to treatment. And then there's a cognitive motor kind of presentation that probably tracks with dorsolateral prefrontal cortical and sensory motor to dorsal striatal dysfunction. And that tracks with motor onset and progressive neurodegenerative course. And that's a lot more resistant, at least from a cognitive perspective. The motor can be a little bit more responsive. Apathy is a primary contributor to functional impairment, and that executive cognitive dysfunction can be sometimes potentially subsumed by this apathy syndrome. And that's just one part, and the apathy is the predominant one. Depression, it has a high association with functional impairment as well, but that is, as I said, it may be an epiphenomenon of some of the ubiquity of depression in this population, especially in the pre-manifest, and how big of an impact that has of individuals who are not otherwise manifesting symptomology. We can use neuropsychometric screening for both surveillance for symptoms that warrant escalation to neuropsychology, as well as for tracking, so we don't have to see the patient back if we're not adding incrementally, and that the physicians in the front lines can be more confident about how this patient is evolving, and if they're responding to treatments or not. But we talked about the different use of the neuropsych, especially in the premotor manifest, and that presently the way we would go about this is to diagnose a neurocognitive disorder due to HD pathology, even if it doesn't meet motor criteria. But I think, as you see in the future directions, non-motor diagnostic criteria is currently already being kind of implemented at the research level. And there's two papers that are out and another one that's coming out that at least have my name on it. And I'm not the only one writing about this. So I think that the field is shifting towards altering the clinical diagnostic criteria of HD to include a more gestalt aspect of cognitive impairment, certainly, and perhaps even behavioral and psychiatric features as supportive or ancillary to allow that threshold for diagnosis to be met earlier. Management options include a breadth of psychotropics, some behavioral and rehab interventions. Most are ameliorated, but symptoms are ameliorated but not resolved. Cognitive impairment is progressive and difficult to manage, and that's frustrating given our specialty. I'll also say with regard to the cognitive impairment, a future direction, there are some recent positive trends for cognitive pharmaceuticals. There's a SAGE trial that has had some interesting findings, but that's not yet widely available, or it's not in the market yet. This was a talk that has been given before in a different setting. I'm just going to update that these are the two papers that were published both within the last 3 months. They both come from the Huntington study group, neuropsychology working group, of which I'm a co-chair, along with Agu Rossetti, who's the second author in both of these. And one is focused more on the neuropsychological practice, and that is the TCN article in the upper left. The other is focused more on the neuropsychometric screening, how to implement this and use this as a neurologist or psychiatrist. How does the neuropsychologist interact at that level? And that's in the movement disorders piece in the bottom right. Both allude to and support a non-motor diagnostic framework as something that should be sought after. Last, I'd just like to thank Vanderbilt HD Center of Excellence, including the director, Daniel Clausen back here, the Huntington Study Group, and the European Huntington Disease Network. So with that, I think that got 9 minutes to take some questions. I'll stop sharing.
Thank you so much, Dr. Considine, for that detailed and comprehensive presentation. I mean, you covered everything, and this is so nice to hear from you, and especially about the work that you're doing clinically as well as in the research world, and letting us know how we in neuropsychology can make a difference, and especially in regards to that criteria.
Sure.
Get my
pleasure.
Yeah.
Thanks for having me, guys.
Yeah, and we have some questions here. Let's see, can y'all see this okay? Dr. Considine, can you see my?
Yeah, I see your
Okay, perfect. So
flash
some of the
screen.
questions that we have, so you talked about some, one talking about some of the screenings that neuropsychology can do in terms of touching base with the physicians. And I know you highlighted the MOCA and gave some examples of screeners and things like that. The question is, are there any specific tools that you like to use, or any specific tests that you think should definitely be included in those screeners?
In the screeners. So for the sake of time, I'll direct them to the movement disorders article that I flashed up before. I don't have a very common name, so Kieran Considine in PubMed or Google Scholar. Yeah, we outlined some options, basically a table that you can review, pick your favorites from before you maybe make your packet and send it to the neurologist or psychiatrist that maybe you're working with, or if you're going to use it in practice, to maybe keep an eye on the clinical status of patients and judge whether you want to have a return or not. There's, as I alluded to, kind of two directions. I think you can go looking for screens that are designed for within the HD community, or finding screens that are kind of symptom or syndrome specific. I don't know if there's an answer for which one's better. It's going to be unique in how much time you have. Take a look at the reliability. We tried to pick the ones that we thought were most were best representative of that. But that would be my approach: is how much time do you have? You want to do HD specific measures that, or do you want to kind of get a little bit wider and have some screens with individual cutoffs that are syndrome specific?
Yeah, thank you for sharing those two articles. And when we have your lecture put up on our channel, our YouTube channel, as well as on our website, that'll be a good place for people who maybe didn't get to take a screenshot or just type in your name, and they'll be able to get on that or find it that way. Relatedly, when you're, you talked about the nausea, that is very impairing, and thinking about for the patient themselves, but also for the families. What types of interventions, or how are you integrated from a neuropsych perspective in, talking to the families about that? And what are you?
Yeah, that's a good question. I've got rehab setting training, but it's not my forte. So I don't engage in intervention much, except in the room when you're doing your feedback and kind of working with the feedback as intervention tool itself. I think breaking the ice and talking in a lay perspective, even for 5 or 10 minutes, can be that the patient and family just hasn't had happen. It's almost, it doesn't come up, or it's ignored, or it's not hit enough times in maybe previous encounters with providers who don't have enough time to do that. And so explaining that this is not a willful or a disingenuous or a malevolent motivated type of denial, that this is a genuine lack of capacity to be aware of the symptoms, and really trying to just emphasize that to can sometimes get through. I think if I were to do intervention or make recommendations, I'll sometimes suggest individuals seek out, family members seek out acceptance and commitment therapy. From my understanding, I mean, it's mostly used for kind of one's own chronic conditions, but it does have a nice emphasis on that stoic feed into third wave CBT of acceptance of what you can manage and what you can't. And that kind of sometimes can shift people's perspectives of, okay, given this fact that's not going to change, how can I go forward and still pursue my value, which presumably some value that's around the connection with the patient or the activity that they want to engage in with the patient. So those are my two types of thoughts. That you'd be surprised how much you can do in 5 minutes, and think about ACT as a recommendation for a family member.
I love that. I think, the words that you were using to describe that lack of awareness is really important to communicate and describe how the patient is functioning and limiting or lacking understanding, but also that thoughtful approach of using psychology and what we also have to offer, and just sharing those resources with patients and families. Relatedly, in terms of thinking about language and communicating, things can easily get lost in translation if you are speaking the same language, especially with this type of topic. How are you and your colleagues in the HD space accounting for any linguistically or culturally diverse patients? Thinking from a culturally responsive perspective, whether it be related to describing the diagnosis, its progression, what that looks like, and any specific measures.
So first, it's critical in all conditions, but it's very critical in rare conditions, because if you're trying to find sufficient sample sizes and correct kind of clinical trial inclusion-exclusion criteria stuff to advance care to the next generation, you need to go global. And so there needs to be kind of an acknowledgement that there's going to be variation from a cultural and language and as well as probably kind of global genetic heterogeneous nature. In fact, one of the biggest HD mutation sites is in Venezuela. And so we actually do have, I think, Spanish-speaking aspects of HD are probably a lot more advanced than some perhaps others, especially in North America. I know Agu Rossetti, the co-chair for the HSG Neuropsych Working Group, she provides those out at Virginia. There's certainly research in that space, and both UHDRS and HSG have made it kind of a plank on their next generation work to ensure that that is an element that's included in the mission going forward. I would have to kind of defer on further comment because it's not an area of my specialization, but I do know that it's become something that's becoming, it's not being left behind. I know that. I think that work also into the biomarker space is attempting to kind of at least supplement some of the variability that might come from the phenotypic presentation affected by culture. And so that the ISS, which is the new research criteria, is beginning to be applied in populations that were previously perhaps at risk for being mischaracterized or not having good clinical assessments. And that might kind of also help us reach these populations. Though we shouldn't give up on trying to make sure our clinical assessment measures are equivalently updated as well.
That's incredible. Thank you so much for speaking to that. Do you have time for one more question? I know we're just...
Go ahead.
Okay. So the participant is stating, I would be curious to hear how you think about the nuance of diagnosing dementia in HD, which has more of a motor component than other neurodegenerative etiologies. So functional impairment is likely due to a mixture of both cognitive and motor difficulties. So how do you ensure that you're not overdiagnosing dementia versus MCI on either side of symptom progression post-motor onset?
Also, yeah, it's a great, awesome question. Yeah, so I think, in fact, I would expand on that question to state that there's also a complication, if you've worked with behavioral variant FTD, of having intact cognitive exam, but having a profound neurodegenerative neurobehavioral disorder and not having the right potential framework to categorize that as an irreversible, behaviorally mediated functional decline. And so I'm going to address what the question was in just a moment, but actually what's more common in my practice is my cognitive exam is frustratingly preserved despite the
Mhm.
obvious presentation of this patient being neuropsychiatrically compromised.
Mhm.
That they cannot hold a job, we've optimized neuropsychiatric medication, behavioral medication as much as possible, but that the changes due to HD pathology have made it so from a cognitive functional perspective, they just can't operate, that they're so disorganized and so distressed in the real world that they should meet kind of a condition. Now, it's also common that that patient that I described doesn't have sufficient motor symptoms to
Mhm.
justify saying that they have active HD. So it frequently falls to me to make a diagnosis to try to assist both this patient in being recognized for their true functional status and to open doors for support and treatment. And I advocate for the use of the neurocognitive disorder with behavioral disturbance.
Mhm.
And I do that in BVFTD sometimes too, and say that this is with predominant behavioral disturbance and obvious neurocognitive dysfunction in the real world, though my exam, due to limitations on the psychometrics and the types of measures that our field has, is missing this particular flavor.
Mhm.
I also tell trainees that the cognitive exam is not tell you everything. It's designed to generate hypotheses and to help you evaluate hypotheses that arise from the clinical and in vivo setting of the patient mixed with the other diagnostics. So just because there's the absence of cognitive impairment on exam doesn't mean that this person doesn't have a neurocognitive disorder. Now, to the actual question of, well, what about the overdiagnosis that you call this a dementia, when the functional impairment criteria is really met by the motor component. That actually happens not as frequently, and that's a result of the cognitive motor findings, the neuroanatomical, neurobiological phenotype findings. That if you have motor deficits, you're frequently finding yourself at a level where the cognitive impairment is sufficient to be called something objectively impaired. Splicing the hairs of, can they not do their pillbox because of chorea versus kind of organization? I agree, but we do that in PD, we do that in LBD, the alpha-synucleinopathies, we do that in other conditions, and I think you use your judgment and you err on the side of conservative, in unless I think you err on the side of doing the least damage to the patient. And
Mhm.
sometimes that means you acknowledge fully the cognitive component that's causing the pillbox issue. And sometimes you say there's just not enough there. And that could be the same patient, just with two different systemic kind of situations
Mhm.
around it. Because our duty is to accurately diagnose, but also not to iatrogenically harm. And so if you kind of follow that error, I think that it's not unique to HD, but I acknowledge it is something that you have to figure out. From a research perspective, it is hard. We try to use measures that de-emphasize motor components, though with the visual motor component, it's one that probably is involved. And maybe in artificial delineation, when you're talking about processing speed and motor control, the overlap gets more and more gray
Mhm.
with relation to the functional impairment. Yeah, that's the circumstance as it stands. I think that's what I would say about that.
Well, that's great. Thank you so much again for your fantastic talk and for giving us extra time and your thorough answers. We really appreciate it, and so does the audience, and we hope you have a great rest of your day.
Likewise, thanks again to Neuropsychology. I enjoyed speaking. You guys have a great product, and I know I use it.
That's great. Good to hear. Thank you.